Everyone. The stage is still a bit hot because Mani set it on fire a few talks ago, and then Vivek came and played God and made you all create fetal circulation. My job is a little bit more mundane. I'm going to talk about a basic test, which is called as NIPT. But this test has actually changed the way we practice because we have people now coming into the lab and making tall claims like, this is the test that will give you a 99% detection rate for Down syndrome with a false positive rate of 0.1%, which is like the best thing you can get from any test. It's telling you that this is a test that is as close to a diagnostic test as possible. Now, over the course of this talk, I'm going to tell you that this is far from the truth. At the same time, it is a very important test, and you should utilize it in such a way that you get the best of this test while not lose out on the best that you already have, that is the combined test. Now, what does the NIPT not do? The NIPT does not separate fetal DNA from the mother's blood and do a karyotype and on that fetal DNA and tell you whether the baby has Downs or not. That NIPT does not do. So I want all of you to understand that. This is not a substitute for amniocentesis or CVS. We are not directly taking fetal DNA and doing a test. If that is not the case, then what is this test doing? For that, you should understand a basic fundamental principle that came out while the Human Genome Project was going on. And what they understood from the Human Genome Project was that in our blood, the proportion of concentration of each chromosome is fixed. Which means if you take my blood or the blood of all the people sitting in this room and look at the proportion of contribution of chromosome 21, it is going to be fixed at 1.3. Which means if you find that the concentration is higher, it means there is aneuploidy. It's higher or lower. So by looking at the concentration of contribution of a particular chromosome, you can assess whether that contribution from that chromosome is more, which means the concentration of that chromosome is a little bit more or less. So what the NIPT does is that it takes all that free floating DNA from the maternal blood, which is a combination of both maternal DNA as well as fetal DNA, and then tries to look at the representation of each chromosome in that collected blood. And if they find that there is an overrepresentation of chromosome 21, we know that the mother does not have Down syndrome, so by default we assume that the fetus has Down syndrome. Now that's how NIPT works. So it is looking at the percentage of contribution of each chromosome, and more specifically for trisomy 21, because that's where it works brilliantly. The limitation of this test is that 5% of the time you cannot get a result. It fails to pick up clinically significant aneuploidies, and sometimes you may need an amniocentesis to confirm your result. Now, why do you get a no result? A no result could be because the proportion of contribution by the fetus is less. Because unless the fetus contributes a significant amount of DNA, you will not be able to be sure whether there is an overrepresentation of chromosomal material in that DNA. And that's the most common cause. And when that fetal fraction falls below 4%, you know that the sensitivity of this test goes down from that 99.9% to 70%, which is similar to that of a triple test. So the first thing that you need to know is you need to get good fetal fraction. Now, how can you know the fetal fraction in the maternal blood if you cannot separate out fetal DNA? I told right at the beginning, you can't separate fetal DNA. So then how do you know the fetal fraction? We look at certain characteristics. Now, fetal DNA is going to be smaller than maternal DNA, and therefore, if you look at the proportion of smaller DNA in a collection of maternal and fetal DNA, you will be able to say how much that concentration is. So it's just by looking at the amount of small fragmented DNA within the whole collection of maternal blood that you will be able to say the proportion of fetal fraction. Again, we are not separating it out. Another method would be to look at DNA fingerprints, which are basically certain sequences that you would find on the maternal and fetal DNA that will allow us to know that, okay, this sequence comes from the fetus, and therefore all this DNA is coming from the fetus, and thereby we can know the fetal fraction, and it works perfectly well when you're looking at twins. So why do you get low fetal fraction? Why is the fraction less? If you go in early and do a test like less than 10 weeks, you're going to get a low fetal fraction. If the mother is obese, you're going to get low fetal fraction. If there is an abnormal karyotype, there is a high chance of getting low fetal fraction. If the mother is on low molecular weight heparin, or if she's got an IVF-treated pregnancy, also you're going to get a low fetal fraction. Now, obesity, you get low fetal fraction because the amount of maternal circulating free DNA is going to be very high. So in a mother that is obese with a BMI over 30, you're going to look at the maternal blood and you will find that there is a lot of free DNA that is coming from maternal cells. And therefore, indirectly, the proportion of concentration of fetal DNA is going to go down. An abnormal karyotype, if a fetus is having aneuploidy, especially those aneuploidies with poor placental function, you're going to get less amount of circulating free DNA. So if you have a combined test that tells you that your papae is very low, it means the placental function is bad, and therefore there is a good chance that the cell-free fetal DNA is going to be less, and thereby the fetal fraction is going to be low. Now, right at the beginning, I said that most companies claim a detection rate of 99%, but that's not true. If you look at a 3% no result rate, for example, if you have 1 lakh women going in for NIPT, and out of which 3% of them will get a no result, you would miss out on 6 of the 200 Down syndrome babies that would be present in that 1 lakh, if you look at the incidence of Down syndrome in general, which means you would have a detection rate of around 97%. So if you have a no result rate, which is around 3%, but actually the no result rate is much higher than that. But let's say you get a no result rate of 3%, you're going to miss out on 3% of your Down syndrome babies. Now, if you directly do an NIPT, and if there is a no result, what do you do then? You can either go in for a repeat testing, that is, you can do NIPT all over again, but then 50% of the time, again, you will not get a result. The other option is, because you have not done any screening and your NIPT has come out as no result, you're worried because I told you again in the beginning that aneuploidy also can give you a no result rate. So you might go and do an invasive test. What will happen? You will do lots of unnecessary amniocentesis. The third option is that you will think that, okay, I cannot do the NIPT, I cannot do the combined test because the time is already over, and you will end up doing a quadruple test which has got a low false positive rate. So it doesn't make sense to do NIPT directly bypassing the NT and the combined test, because if you do the combined test and if you get a no result on your NIPT, you still have the combined test to fall back on, and you can decide on using that combined test result to decide what you want to do next. You can either go in for invasive testing, or you can do a genetic sonogram and modify the risk of the mother and decide whether you want to do invasive testing or not. So the first point is, we are not going to do NIPT directly. Now understand that NIPT is not always correct. You can get false positive results. And the most common condition that can create a false positivity is confined placental mosaicism. Here what happens is that you have an embryo that was aneuploid to begin with, but as the gestation progressed, autocorrection took place in the fetus, but the placenta remained aneuploid. And therefore, the cells that are being secreted into the blood are going to be abnormal, while the fetus is normal. And that's why most of the people say that when you get an NIPT result that has come out as positive, you should do an amniocentesis, because the amniocytes are truly predictive of the fetus rather than a CVS sample which looks at the placenta. But having said that, CVS can be done in selected cases, and those selected cases would be trisomy 21 and trisomy 18, because these two conditions are very, very rarely associated with confined placental mosaicism. You can also do a CVS if you have a scan finding that tells you that this baby looks like trisomy 13. It makes no sense to wait for amniocentesis. But if you have an NIPT result that tells you that there is a possibility of trisomy 13, do not go and do a CVS, because in a normal looking baby, it's highly possible that you're looking at false positivity. Wait and do an amniocentesis later on and be sure whether your result is normal or not. Another common indication is when you have a vanishing twin. Now, by definition, you have a twin that vanishes off very early and it then goes on as a singleton. And when you're doing your 11 to 14 week scan, you might not be aware that this is actually a twin pregnancy that has become a singleton right now, and you might send in for an NIPT, and there again you can get false positives. But if you're working in a center like an IVF center where you know that this is this was a twin pregnancy before and there was a vanishing twin before, you can still do NIPT if you time your test correctly. And you time your test 8 weeks after documental fetal demise. So if you have a first trimester scan at 6 weeks that tells you that there is missed abortion, you follow it up and 8 weeks later you can do an NIPT if that is what you want to do. Maternal malignancy can cause false positive results, because if you have a malignancy like a sarcoma or a breast cancer or something like that, you will have a tumor mass which is going to shed DNA into the maternal blood. And this shedding of DNA or shedding of cells into the maternal blood is going to lead to what? Overrepresentation of chromosomes, which will lead to a false positive NIPT result. And this particularly happens when you get an NIPT result that is positive for multiple chromosomes. It will come as NIPT positive for trisomy 3, trisomy 4, trisomy 18, which means for multiple chromosomes you're going to get an NIPT positive result, and there you should think about malignancy. The next thing you have is maternal mosaicism, where you have a mother that is having a mosaic condition, like say mosaic Turner's. She will be subfertile, but she may become pregnant as well, or she has undergone IVF and become pregnant. Now you know that she has got a deficiency of what? An X chromosome. And that will be picked up on NIPT. NIPT will see an underrepresentation of the sex chromosome, and you will falsely attribute it to that of the fetus. So there again you should remember that if there is maternal mosaicism also, you can get a false positive result. Now in twins, what is the best screening tool? If you look at twins, if you do NIPT, the biggest problem here is we do not know the contribution of fetal fraction from each of these fetuses. The fetal fraction of both these fetuses is going to be small, so the size criteria cannot be used. You need something else. And that something else is SNP based techniques, which looks at the DNA fingerprint of each of these fetuses and tries to differentiate the fetal fraction from each of these babies, and thereby gives you a more reliable result. But SNP based techniques are not widely available across India, and in Kerala I don't think they are available, and we do not do them. So what is the way out of it? You can still do the NIPT, understanding that there is a higher chance of false negativity here, because you're not able to judge between the fetal fraction of both these fetuses. And NIPT is a far better test than the combined test for twins. So if you ask me in twins, which is the best test, I would say it is to do a good NT scan and follow it up with an NIPT, because your detection rate here is going to be much higher. Now what if you get an NIPT positive result? How will you counsel this mother? Are you going to tell her that the NIPT result is positive, so you should definitely terminate the pregnancy, or the chances are very high and it's very unlikely that your baby is going to be normal? It's not the case. You should understand that NIPT is also based on the age. In a low-risk woman, you can see that the chance that the baby will have Down syndrome, if the NIPT result is positive, is only 45%. But in an older age group woman, the same NIPT result has a different positive predictive value as high as 77%. So understand that when the NIPT turns out to be positive, you can tell her that her risk is high. And if she's of the younger age group, say that in spite of having a high risk, you still have a 60% chance that the baby can still be normal. And that's what you should tell before deciding to counsel her about amniocentesis or other invasive procedures. Now, if the test comes out as negative, what do you tell the mother? If the NIPT comes out as negative, what are the chances that this baby will have Down syndrome or a trisomy 13 or an 18? It's important to understand that the negative predictive value is not dependent on the age. If the NIPT is negative, the negative predictive value is 99.9%, and it is the same for the combined test. If you do a combined test and if it turns out to be negative, it means exactly the same thing, 99.99% negative predictive value. So if two women come into your OP and both of them have got different results, but different tests done, but the same results. Combined test negative for one, NIPT negative for one. The risk of having a baby with Down syndrome is exactly the same for both of them. It's less than 99.99%. Now what about other trisomies? You're going to get a lot of lab people coming up to you and telling you, do NIPT for all the chromosomes. Why just trisomy 21? Don't you want to know whether you're going to get a trisomy 1 or a 2 or something like that? These are called rare autosomal trisomies, or RATs. Now, rare autosomal trisomies are rare for a reason, because they are not very common, and most of them are going to have an abnormality on ultrasound. But what's more worrying is that some of them may be confined to the placenta, like trisomy 16, and you will do an NIPT and find out there is trisomy 16 on the NIPT, whereas the fetus is going to be absolutely normal, and therefore we do not recommend NIPT for rare autosomal trisomies. Then you have another set of people coming in. Again, the lab people will come and tell you, what about microdeletions and duplications? I've got a test that's going to pick up 22q deletion. I've got a test that will pick up 4p deletion. Why don't you give it to all your patients, especially your IVF patients? That's what they're going to tell you. These people have got a premium pregnancy. Let's do an NIPT and look at their copy number variants. Now, the problem with copy number variants is that we do not know the prevalence of these copy number variants. We should know the prevalence to institute a screening program. Without knowing the prevalence, we should not try screening, except for 22q. Rest of the microdeletions, the prevalence is not known. That is one point. The second point is, we do not know the phenotypic expression of this disease. If I say that the baby has got 22q deletion, I should also be able to say what to expect from this baby. Is this baby going to be mentally retarded? Is this baby going to have a congenital heart disease? Is this baby going to have thymic hypoplasia? I cannot answer any of those questions. The diagnosis of 22q deletion has got value when it is made in retrospect, after you have made the diagnosis of an abnormality. When you have picked up a congenital heart disease and you know that the baby has 22q deletion, it makes sense. Whereas a completely normal fetus, if that fetus has got a 22q deletion, it is impossible for us to predict what the outcome is going to be. Whereas in Down syndrome, we are absolutely sure what the phenotypic expression is going to be. So you are not going to test for diseases for which you do not know what the phenotypic expression is going to be. So if a lab person comes in and tells you that I can find out if there is 22q, you ask him what is the phenotypic expression of 22q. If he is not able to answer that, you cannot apply it in routine clinical practice, and I would say no to NIPT for copy number variants. What about if you have a structural finding, or if the NT is greater than 3.5, that is the 99th centile across all CRLs? In these conditions, do not go for NIPT. I would want a diagnostic test, because a diagnostic test will tell me whether there is a problem or not. I would not go for a screening test. And whenever you do a karyotype or a microarray, the chances that you will pick up an additional abnormality is as high as 8%. So no NIPT in this group. Now, after hearing all this, how do we use NIPT? What is the take home of all of this? Now, some of you might think, let's do NIPT for all. Let's do NIPT for all our patients. Let's do a good NT scan. Let's look at the anatomy of the baby at 11 to 12 weeks, and let's do an NIPT for all. Now, when you do that, 3 to 5% of the time, you're not going to get a result. If the test turns out to be positive, you might have to do an amniocentesis later on. You will miss out on screening for preeclampsia. You will miss out on all those chromosomally significant aneuploidies which are present in the high-risk group of the combined test. The combined test, although is a screening tool for trisomy 21, 75% of clinically significant microdeletions are present in the high-risk group of the combined test, that is above 1 in 100. You will miss out on all of them. And of course, the cost. You cannot do it on a large-scale program. So NIPT for all is out. The second option would be what the FMF is doing, to classify women into 3 groups. The first group being the high-risk group on the combined test, which is around 1 in 10. And the second group would be the intermediate risk group between 1 in 10 and 1 in 2,500, and the low risk group being 1 in 2,500, where you would do no testing. But here again, 25% of your population will require NIPT, and that will be huge when you think about the cost constraints. What we do at our center, and what we have been propagating for long, is to shift the cutoff to 1 in 100. So the high-risk women who are above 1 in 100 will get an amniocentesis. 1 in 100 to 1 in 1000 will get the NIPT. Greater than 1 in 1000 will go home. Now, the advantage here is that by decreasing our cutoff from 1 in 250 to 1 in 100, what are we reducing? We are reducing unnecessary amniocentesis. At the same time, we are not compromising on our detection rate, because we are offering NIPT into that group. And by offering invasives into the 1 in 100 group, we are significantly increasing our detection rate, not just for Down syndrome, but for all those clinically significant aneuploidies. So our take would be combined test and 12 week scan are indispensable. Divide women into 3 risk categories and use NIPT for the intermediate risk group. Thank you. Thank you for listening.